Bacterial pneumonias, some viral pneumonias. We're going to continue that discussion today and talk about some other lung diseases, parenchymal diseases. We'll talk about tuberculosis, which I think this is probably the third time you've seen stuff about tuberculosis. Yeah. So I'll tell you now, there might be some variations to the guidance that we have in some of these lectures. Always new treatment guidelines coming out. Always new assessment guidelines. So if you see anything, blatantly obvious, I tried to cross-reference with micro and farm and ID to make sure that you're getting consistent information. If you see anything that's way off, let me know just so I can make sure we mitigate that. All right. Again, PANCE topics. These are all on your PANCE blueprint. So when you get ready to take the test, these are topics you're going to want to make sure you understand how they present, how you diagnose them, how you treat them. As far as yield, high yield, it depends on where you're going to be. So if you're in places where tuberculosis is common, you'll see it more often. So as military, this stuff might be more common than, say, someone that's just working in the US. Versus, I saw a lot of cocci, but I did my training in Arizona. So it just depends on where you're going to be and what kind of populations you're going to be taking care of. So tuberculosis. The other word for tuberculosis is consumption. It consumes the body. Tuberculosis, like pneumonias, influenzas, have had significant impacts on the overall health of populations, public health. So it came to the U.S. initially with immigration, and we discovered what bacteria was causing it. At the time, 1 in 7 people died from this. There were some really crazy ways to treat this back then. Royal touch, if you had it and you were touched by someone in royalty, then that would cure you. We have all these crazy ways that we treat things until we get to modern day science, and then 100 years from now they'll look at us and think we were crazy for some of the stuff we did. So people started to notice trends. People that were in warmer climates, less humidity, did well, so they started to move them out to the west. One of my husband's favorite movies, Tombstone. I think that's where he ends up. Doc Holliday ends up in the sanitarium out west in Colorado. He had tuberculosis. Mid-20th century, we started to introduce antibiotics. Some of those antibiotics had severe side effects. So back then, weighing the cost and benefit was a bigger deal because the treatment could actually cause more problems than the actual disease. Today it's highly treatable in the U.S. The biggest thing now in terms of medical care when it comes to tuberculosis is ensuring that we are doing our due diligence to treat it and not to continue to create these drug-resistant strains. This is a big issue. Something when you think about tuberculosis, we'll talk later on how to treat it. Aside from screening for it, which is a huge part of our public health process here, aside from screening for it, looking for risk factors, actually testing for it, screening for it, right? It's also very, very important that we treat it. In fact, when you have patients who have tuberculosis, in most cases, it's treated by a specialist, either off health or pulmonology. We want to make sure that the patients are treating it. So we call it the consumption. It is a causes systemic disease. It's not just a pulmonary disease. This is Doc Holliday early in life. This is him later in life. So it consumes the body. Lots of coughing, lots of metabolic rates up. People lose weight. Fevers, chills, nausea, all those constitutional symptoms, night sweats, signs of systemic disease. So that's a tuberculosis picture right there. So a patient before they were treated and after, again, the patient looks gaunt. Malnutrition, it's all part of that. So this is just an overview. So not a huge burden in the US, however, in the military, we do go to places where there's still high incidence. And globally, this is the leading cause of infectious deaths. Very unique thing about tuberculosis is that it has a latent phase where patients are not symptomatic. And this is the time where we're screening for it in the latent phase. So risk factors for people that, obviously being in an area where tuberculosis is prevalent, that's obviously one of the risk factors. Being around it, being around active disease, being in places where there's not a robust public health that's screening for it, that's managing it. There's not a lot of money going into managing this disease. Otherwise, again, this all points to a disordered immune system, which is true with a lot of the diseases, especially infectious diseases. Disordered immune systems, undernutrition, diabetes, being HIV positive, those all lead to disordered immune systems, and so patients are more at risk for contracting tuberculosis. So these three things at the bottom, this is where you're going to see some variation between your literature, but in general, patients have where they first are exposed to the disease. When patients are first exposed to the disease, unless you have a high clinical suspicion, a lot of times you'll miss this because it looks like any other upper respiratory infection. Chest x-ray findings aren't really there. You might see some patchy opacities, and your brain will go, oh, they have a viral pneumonia, right? Or they have some sort of virus. Because unless you're thinking tuberculosis, unless you're asking about recent travel, unless you're asking about recent exposures, all those little questions we learned in medical history, you're not going to be thinking of it. So a lot of times patients in this primary phase will go undetected. And then the way that we screen it, typically with the skin test, that will usually be not detectable because the patient has not developed the immunologic response that we need for it to show up on that skin test. And then this unique latent phase, this term granuloma, have you guys heard granuloma before? Okay. It's a immune process in the body, and it's something that helps us differentiate between different types of diseases. This disease acts this way, this disease acts this way, so that we can use it in diagnostic ways. So, these granulomas form. It is an immune response. Then they capture that live tuberculosis. So good job on us. So even if your immune system's compromised and you contract it, your immune system typically in most people will be functional enough to form these granulomas to capture this tuberculosis. Typically keeps it in the lungs. So patients will not have active disease, rarely transmittable. Sometimes patients stay in this their entire life and we never know that they had contracted tuberculosis. They contracted it, they otherwise lived a relatively healthy life where they had good access to food, they had not any immune problems with their body, and sometimes they can go a complete lifetime without ever reactivating. You can see, if they're present, you can detect these granulomas and nodules on the chest x-ray. And then the other way that we test for it, the PPD, which we'll talk about, that also becomes positive during this phase. So 2 ways we can screen for tuberculosis in higher risk populations. We'll talk about what that means. So this is why chest x-ray is usually part of screening. So those things are present even though the patient is not sick. They're coming to you asymptomatic. Very important differentiation, because then we talk about reactivation disease. And this is when we have patients coming in and they are coughing and coughing and coughing and they're really sick and they've got high fevers and you say, do you have any night sweats? And no one's ever said yes to that before in your life, right? And all of a sudden they're like, yeah man, I'm waking up, I'm sweating at night. And you're like, oh crap. And it's not automatically tuberculosis, but that's why we ask the question. So patients become very, very ill, high fever, coughing their brains out. Usually, the patients that I've taken care of that had active tuberculosis, they were slightly malnourished looking. I've never seen like a robust person come in and they have active TB. Usually there's some contribution of malnutrition in there. There's some contribution of maybe having comorbidities or other diseases where those granulomas, even though they had been doing a good job for maybe years, no longer were able to keep those bacilli contained in that area in the body. So we talked about, right? So these are the patients usually, they end up on high dose steroids, that disrupts their immune system. HIV develops into AIDS, or they have other end-stage diseases that cause immunosuppression. Chest x-ray, in this phase, we'll show you what that looks like. Hilar lymphadenopathy. So when you get a sore throat or you get an infection in the throat, usually these lymph nodes get activated. When you have a genital outbreak, right? Usually your inguinal lymph nodes get activated. Tuberculosis, it's those hilar lymph nodes that'll get activated. And you can sometimes see that on chest x-ray. So hilar lymphadenopathy, so lots of little lymph nodes, nice and bright and white and full of fluid because they're activated around that hilum. And then apices, so TB loves oxygen. And classically, we'll see that up in the apices when it does reactivate. The clinical features, typically, we're diagnosing it during that reactivation phase. When patients are coming in, they're tired, they're not eating, they've lost weight, they have fevers, they have night sweats, all those constitutional symptoms. TB is like the mother of all when it comes to constitutional symptoms. And every time I had somebody that says positive night sweats, I would be like, oh, you have TB, you know? It's like, no wait, this is a 52-year-old woman who's coming in complaining of mood swings and whatever. So maybe those weren't night sweats, maybe those were hot flashes, right? But it's something you need to ask. So cough is going to be your most prominent. Initially it's going to be dry, but as the reactivation progresses and all those bacilli are attacking the parenchyma, it's going to probably end up causing some hemoptysis, some blood streaking. So they'll be like, man, I've been coughing for a few weeks, I've had these high fevers, but what really made me come in was because now I'm seeing blood in my sputum. Oh, and by the way, I spent 2 months in Mexico down in a high area of tuberculosis 2 years ago, and they did some tests and said maybe I had this, but I never got seen. So anyway, it's just very, very something that you have to have in your brain, because as soon as you determine that this is potentially in your differential, then you need to make sure that you're isolating them. Make sure that the patient has a mask on. Make sure that the patient is away from other patients, because it is highly, highly contagious in this phase, in this reactivation phase. They're just, and then the cough really, bugs are smart, right? So they're smart. They wanna get out. They wanna move on to other organisms, and so causing that cough will cause the patient to push that bacilli out into the air. So make sure they get isolated. Labs, you can do a lab for this. You take a sputum sample, you can look at it under the microscope, preferably 3 consecutive mornings in order to rule it out. Sputum's always a hard one to really get good cultures on. That's why sometimes if we're struggling with diagnostics, we'll actually have Pulm do a bronch to get good samples for us. So 3 morning samples of sputum. You can look at it under a microscope, culture it. Problem is, it takes a long time to get the results back in general. So do you sit there with the patient isolated and wait for the results to come back before you treat them? So that's one of the big challenges of diagnosing TB, is that the tests we have, either it takes a while to get the results back, or it's very limited availability. And again, this is one of those, it depends on where you're at. Places that see TB a lot probably have this capability. Places that don't see TB a lot probably have to go the old route. And the chest x-rays, again, primary phase, that's that first couple weeks right after they've contracted it. They're kind of not feeling good, maybe they have a low-grade fever, they're coughing, they just feel like they have the flu, right? I feel like I have something's going on, a respiratory infection, I need some Z-Pack. Sometimes you can see some, but it's only about 30 to 40% of the time. So get the chest x-ray. If patients come in and there's a clinical indication or you're concerned about it, but usually it's not diagnostic. The latent phase, we talked about those granulomas. Anybody know what the word caseating means? Yeah. Got a case on it. So caseating versus non-caseating. So it has to do with the material inside the granuloma. So caseating is when there's stuff in there, like bacteria and purulent material, and so there's versus non-caseating where that's not going on. So it's bacteria related. You get that calcified shell, and then in the middle you've got that organic material that's forming purulent material, and that's causing those changes. We'll talk about sarcoidosis later on, and that would be one of our non-caseating, and it becomes a way to differentiate these things diagnostically. And reactivated, and we've got that consolidation. TB loves the apices, likes oxygen-rich areas. This is classic for reactivation. All right. Here's the PPD. I pulled the USPSTF recommendations. So who gets a PPD? And the answer is people that are at increased risk for latent TB. So it's where you were born, mostly, who you've been exposed to, whether you're in high-risk congregate settings, correctional facilities, homeless population. I was part of a group that went out and did directly observed therapy for homeless population in Seattle. So every day we would go out with all of our latent TB treatments, and we would go hand them out with other stuff to our patients, our homeless population that we had identified as positive for latent TB. So we would go out every day and hand out INH-based patients to ensure that they got treated as part of a public health movement to decrease the risk to the rest of the population. Here's the skin test. Anybody ever involved in one of these? Placing them or reading them? Yeah. So never place one on a Friday, right? Or a Thursday. Never place one on a Thursday. You can do a Friday. You can read it on Monday, but never place one on a Thursday, or you'll be coming in on Sunday to read it. So this is the tuberculin skin test, also called the PPD. Not recommended for active disease. That's when we're wanting to either get the PCR if we have availability, or we want to get the sputum culture. But for screening for latent, it's part of the recommendation. It's something that we did regularly when I was starting training so many years ago. It's pretty good sensitivity, meaning there's not going to be a lot of false negatives, but its specificity is crap. So it's not crap, but it's not great. It's not, there's a lot of problems with placing it, there's a lot of technical issues with reading it, and then there's a lot of other things that can cause this to be positive. So we've used it for a long time, it's kind of a standard, but there's a lot of problems with the sensitivity and specificity of this test. In duration, when you look at these, we'll talk about looking at the reaction. One of the things that I was taught when I first started getting trained to read these was don't look at it, feel it. So don't look at it because you're going to be looking at the erythema and get distracted. They said feel it. Induration is like where you get that raised area of skin. They describe it as like a woody feeling. So it's kind of hard, indurated, that's what the word means. So feeling it is the way that you want to identify the area of reaction. Don't get distracted by redness. This one at the bottom, it's not number 1, it's number 2, but this is what I got tested with when I recently got screened when I got privileged at BMC. When I was first training, this was like saved for like rich people. Right? So I had to fight to get this when it was first coming out because I had patients, I was doing a lot of immigration physicals at Fort Huachuca, and I had patients that had a vaccine, the TB vaccine, which we don't typically give here. So I couldn't use the TST because they were going to be positive. So I was stuck. So that's the way I opened the door to be able to access this quantiferon. It's an easier test. It's a blood test. Comes back relatively quickly. It doesn't require half the manpower. But when things are new, we kind of protect them a little bit. Now it's become a little bit more mainstream. So again, when I could have gotten the TST, but when I got screened last time, they just said, go get this blood test. And it's nice because it's got better sensitivity and specificity. It's not perfect, but it's better. And then again, you don't have to rely on all the manpower issues and all crap we place on Thursdays. Who did that? Great, you're the one coming in Sunday to read it. So we don't have to do it again. Because they have to be read 48 to 72 hours after placement. That's part of the criteria. All right, here's a little picture. Again, if you look at this picture on the right, you can see the erythema goes way out here. But that's not what we're measuring. We're measuring this raised, firm area. That's the response that we want to assess. And that response would be read as 10 millimeters. We will talk about this chart during the review. Don't put too much power into memorizing it. The important part for you to know is that there's different criteria for what we consider positive based off of the patient. You have to consider the patient when you read this. Is this a patient who's completely healthy, no known risk factors for TB, which is going to be most of our population. Most of our population have access to health care in the military. So when we're screening new patients coming into the medical facility, or we're doing screening once they've left theater, most of our patients are healthy. This middle range, some comorbidities based on the age, if they're IV drug users but HIV negative, if they've been in endemic areas that make them higher risk. So we lower the threshold for what we call positive. If you get a positive, you will not manage these patients. You will send them to an health doc who is significantly higher trained in this, and they can differentiate the nuances, and they can make that final determination on whether. So this is a screening test. Screening tests are designed to be cheap and easy, and they technically, the goal is not to miss a lot of stuff, but they catch a lot of stuff that isn't cancer, isn't TB, isn't what we're screening for. They're designed that way. And then that's the referral then is, we have a positive TB TST, let's get them to a higher level to make that differentiation, to make that final diagnosis. But you will be involved in screening patients, certainly. So understanding, based on your population, there's going to be different variations of what's considered positive. And you will look these up. You will have someone from your clinic come over because you're the only provider that's left because you're still starting, and they're going to say, hey, I just read this TST and it's this. And you're going to be like, man, I don't know if that's positive or not, but I know that there's guidance somewhere, right? And then you can look at that, educate yourself a little bit, and then you make a phone call. You know, get yourself a memory so you look like, you know, you went to IPAP, and I'm proud of you. But then you make that phone call. Hey, why are you calling me? Because I have an induration of this many millimeters, and I've got a patient, this patient had a gastric bypass. Right? And they had a we measured it at 10 millimeters, right? So it's this guy right here on the right, and this person had a gastric bypass surgery. You go, right, you make that phone call. And then they'll say, okay, yep, let's have you send him over. Now, these patients aren't symptomatic. Symptomatic's a totally different boat. If the patient has symptoms, this is not where we need to be having this discussion. If that patient needs to probably be isolated, and then that phone call probably to infectious disease. Because you're not going to want to place a TST on them, because that's not how we diagnose active TB. And then chest x-rays, I'd probably wait on that too. I'd focus on isolating them and then contacting someone. They can help you set up the proper way to evaluate someone who we suspect TB in. All right, so treatment. So treatment, the goal of treatment is to get rid of all the TB bacilli and to avoid medication resistance. And everybody here already knows we create resistance by half treating things. And we give them a little taste of that, and they get smart. And they're like, oh, I'll admit, all right. I know that. And then they get smart. And they start to figure out a way to have that antibiotic not work as well. So resistance means, that's why when we prescribe antibiotics, if you start taking it, finish it. Even if you feel better. Even if you feel better, just finish it. Well, if I already feel better, why should I finish it? Because we want to make sure that we kill off all that bacteria, because now they've seen the enemy. That's a terrible way to put it, but that's what we're doing. Principles, we want to prescribe multi-drug regimen based on susceptibility. So again, this will be a specialty care decision, combination of OC health and infectious disease. They will just decide what that regimen is going to be. Obviously considering patient themselves, any allergies, any previous treatments, things like that. Any comorbidities, do they need a renal dosage, et cetera, et cetera. This one, ensure treatment compliance. Oh my gosh. So patients need to be compliant with this. This is like slightly above oral contraceptive pills, right? You need to take it every day. It's very, very important. This one, you need to, sometimes we have people come in every single day to give them their pill. Sometimes you go out into communities and you have your 10 homeless population folks that have been screened positive for latent TB, and you go bring them their pill every day and some food. So you need to make sure that they're compliant. Most patients, especially in the military, they'll get a 30-day supply. But part of your job as a primary care manager, if you're part of their care, is to make sure that they're compliant. You see them in between. We've got big clinics set up for this. They're called OC health clinics and public health clinics. We want to make sure that they're compliant. All right, so here's the active TB regimen. This is one of, I think CDC has like a bunch out now. They've got some new drugs in there. They're really fancy. This is one of those where, wait to see when you get out there. If you have a chance to rotate through public health or infectious disease as a elective. I thought infectious disease was one of my, next to nephrology, was one of my most eye-opening rotations I ever did. I loved it. I learned how to use bacteriograms, so pick antibiotics, so very good rotation. So again, we usually start broad. We hit them for 6 months, not 6 days, not 6 weeks, 6 months. We hit them with multiple drugs. All 4 in the first 8. And then we usually bump down to less of those to finish up at 6 months. Now this is traditional, this is kind of standard. This is we're not considering resistance, we're not considering allergies, we're not considering previous treatment. This is just a general guidelines is that we broad coverage. We're trying to ensure that we're not falling into that resistance. We keep them on it at least 8 weeks, and then we start to pull them off and continue up to 6 months. Sometimes longer. Sometimes we go up to 24 months when we have resistance, known resistance. Again, public health and infectious disease will guide this. And then latent. I know that Pharm teaches you, I think this is like one of her test questions. So I wanted to make sure I brought it back out. There's several different regimens depending on what you're looking at. If you look at current, which is my reference for this course, this is preferred. If you use the reference for my course, this is preferred. If you look at published guidelines outside of references, this is preferred. So I'm not going to ask you which one's preferred. I think the important part is INH is part of it. Does anybody know how we reverse INH toxicity? Say it.
Yeah.
But did I tell you that story? No. So I got pimped in the ER once at Fort Hood. I was a med student. And I was like pissed off about standardized tests because I had not done well on the boards because I didn't know how to study. And I'll be dead honest with you, I didn't know how to study. I had like textbooks, not USMLE, not test questions. I was looking at like Harrison's and Habib and all these medical textbooks, trying to read them and take boards. So totally screwed up on that. So I was very sarcastic about standardized tests and how does that really assess whether or not I'm going to be a good doctor or not. So I had this whole diatribe for this ER doc. And he's like, well, there's stuff you just have to memorize. I'm like, no, I'm always going to be able to look it up. Of course, I shouldn't have said this in the ER. Because as soon as this patient, the service member came in, they'd been given, he was completely obtunded. He was tachycardic. He was, I think his respirations were like 6 per minute, or 6 per minute. So he was not in good shape. External rub, nothing. Did the glucose, did all the normal things you do. And this peds resident went back and sat at the computer and started looking up the patient's record. Thank God she did, because she found out he had gone to the public health clinic that day. He, forget where he was from, but they had trained him. He was positive for latent TB, no symptoms. They gave him a month's worth of INH. So he didn't understand, or maybe he did understand, that he's not supposed to take all 30 tabs, which is apparently what he did, and he came in with an INH overdose. And as soon as the resident said that, you know, the ER doc's ears perked up. He got like, oh my gosh. And the resident looked at me and goes, so what do we give him? And I was like, he's like, you have to memorize some things in medicine. So I got shut down on that argument, but I always keep in my head, there's some things that you just need to know, but usually that's an emergency situation. So if you're an EMPA or when you go out somewhere, memorize your BLS drugs, memorize your ACLS drugs. Have a little cheat sheet for tox in your pocket. All right. Again, 6 to 9 months, long course. Here's another thing we talk about. So INH, we talked about early TB drugs actually being more toxic than the actual disease itself. So we've gotten a lot better, but we're not perfect. So INH can cause significant neuropathy. So it used to be considered B6, now it's just part of the treatment regimen. If you're giving INH, then you give proxapine with it. Again, this one, a little bit newer as a recommended or preferred. I like the 3-month thing. If that's actually efficacious, that has, this is probably what we're going to end up going more towards, just to keep it down to 3 months. Keep the cost down. So just some additional considerations. We've got these baseline labs. So you will not be ordering these, but you are part of the care team, and so if they get these ordered on the first day, and you see them 3 days later because you have to put a profile in for them, this is something you need to make sure you consider. Make sure they got the labs, right? Did you get your labs? Check them, make sure they weren't pregnant, if they're female. Look at their LFTs. LFTs are important because some of these drugs we can potentially put them on can cause, can influence the hepatic function. And then we're not, right, down here, sometimes we have to do DOT. daily, but usually most patients, as long as we're clear, they understand it, that they have to take it every day, they have to come back every month. In general, most of the population that we're involved with, we can rely on them to be able to go home and take a tab a day for 30 days. This is FYI, I don't expect you to memorize this. It's hard per se, but certainly giving paroxetine with INH, that's something we've already talked about. But understanding that depending on what meds they're on, we should be ensuring as primary care managers that someone has not only ordered these, that's step one. Step two is the patient actually went and got them drawn. Third step is someone actually looked at them and ensured that they were normal. So one team, one fight, be part of that process. All right, so that was TB. Any questions? Did I go way off from anybody else's lectures? Okay. All right, so these ones, this will round out the rest of this lecture. These are mycotic, so fungal. And pneumonia, it's a lung disease, so this is going to affect the parenchyma of the lungs. These are not going to be high yield necessarily, unless, like I said, when I was in training in Arizona, I saw, especially in inpatient, I saw probably more cases than other people would see in other parts of the country because it's endemic to that area. These are pneumonias that aren't going to probably be in your initial differential unless you get a really, really, really good history and the patient read the book and said, I was cleaning out an abandoned barn and there was bat feces everywhere. Okay? So getting that good history. This is probably one where you're going to treat it and you're going to say, come back and see me in 2 weeks if this doesn't get better. And then they'll come back and see you and you'll go, you know, I need to figure out maybe there's something else going on. The good news about all these is, in general, it's only rarely a severe medical issue. I mean, when we talk about HIV pneumonia, unfortunately, there's a lot of stuff that goes on with that particular illness or disease. But the rest of them, most patients don't need to be treated for it. So that's the good news about it. It's not very common, but it's one of those things that when patients get it and they have significant disease, joint pains, rashes, prolonged respiratory symptoms that are severe beyond several weeks, and you're able to think of this and test for it and treat for it, and that's like a gold star in medicine. So be aware they exist. So this is the histo. This is one of the ones we're going to talk about. Ohio and Mississippi River Valley. Those will be your buzzwords in your questions. One of those states will be mentioned. That'll be your first clue. We're talking about this particular mycotic organism. So this one's called river fever. I don't know why. I won't reference that term. Again, Ohio and Mississippi River Valley. Bat and bird droppings. Caves, abandoned buildings. This is my little, remember that picture for histo. My little buckeye right there. So this guy's doing it right, this guy's not doing it right. So bats and birds, dealing with the droppings, that's the kind of picture you want to put in your head. That's the conversation you want to have with the patient. Any exposure to this? Any recent travel? They might be like, what are you talking about? Be like, I have to ask. You know, this is just part of the screening process. So that'll be your patient. Excavating, construction, down in the caves with a bunch of bats. What do you do for a living? Oh, I study bats in caves and whatever. Oh. So, social history is important. Recent travel is important. Recent exposures is important. Again, 1 to 2 per 100,000, and I put that we know about because most patients will get this. It'll go away, they'll never know they had it. So clinical features, again, in immunocompetent patients, most people will get it and they'll have little or no symptoms. Most go undiagnosed, so that's okay. Sometimes we get a chest x-ray for something totally unrelated and we're like, oh crap, there's a nodule. So they go into the ER, somebody's just like, get a chest x-ray on them, run them through all the gamut, and they really didn't have a clinical indication for a chest x-ray, but they got it, and then they're like, oh, there's a nodule, go see your PCM. That's my favorite. We'll talk about following up on those. I have lecture on that. I'm following up on nodules. So they'll come back and see you and be like, I have this nodule, and you're like, oh, well, it's probably nothing. But that's sometimes how we figure out someone had histo. So there's two clinically apparent forms, right? We've got that acute pulmonary histoplasmosis. So usually 1 to 6 weeks, headache, fever. This is when it presents. So usually patients, if they're immunocompetent, they're just like, man, I was feeling like really crappy for like 4 weeks. It went on forever. You might have had histo, right? But they never really get to get treated. Their immune system clears it. Maybe they have a little incidental granuloma now or nodule in their lungs because they had it, but it's not really clinically significant at that point. It's not going to reactivate. It's not like TB where there's a latent phase now and we're waiting for it to boil back up. So there's no reactivation. So frequently misdiagnosed as atypical pneumonia. Again, most of these people are going to get better, so no harm, no foul. The thing I want you to keep your mind out for is, what if we're in this 2-month period, right? We're in this 2-month period, and the patient's still having significant symptoms. They're still having, like, I'm getting this weird fever, but I get it at home. And maybe one time when you've seen them, you caught like a 101. And you're like, huh, you do have a fever. And you get this chest x-ray, and you see this little nodule there, but it's got nothing exciting about it. These are the patients I want you to think, like, could this be something else? And having things like mycotic pneumonias in your differential, maybe you've never asked them about recent travel. Go ahead and ask them then. Because if you can identify it, right, you can test for it, rule it out. Even if it's the 3rd visit, I don't care. Order it, rule it out, let's start thinking about something else. Things that you can certainly order and rule out. Things that if you sent this person to a specialist, they would probably order that. They probably have a standard panel that they order, probably includes some of these mycotics, but you can order this, you can look for it. All right, confirmatory, so the urine, obviously the urine and serum, they're not perfectly sensitive and specific. You need a tissue biopsy to confirm it, but this is usually how we diagnose it. Patients usually don't need that. The other kind that we have, and this is what you potentially will see in the hospital setting, especially if you train outside of military treatment facilities like I did, is this progressive disseminated. This is very, very rare, but it makes this disease significant because in some immunosuppressed populations, this can wreak havoc on their body. And it absolutely has to get treated, or the patient's lethality rate is significantly high. But very rare. That's something that if the patient's immunocompromised, so knowing their past medical history, knowing their immune status, whether or not they're immunocompetent or immunosuppressed, is always of clinical importance when you're evaluating a patient, especially for something that you think might be infectious. Itraconazole, so good old itraconazole. That's how we treat it. So giving them a course of itraconazole. I had a brother-in-law who was hospitalized for about a week because he was building highways down in southeast Arizona. I thought it was TB because they were working with a lot of people crossing the border, but it ended up being Coxy, and they gave him itraconazole. He took it for a little bit longer than you'd normally take it. He took it for 2 weeks, but it's a fungus, so we use antifungal. When the patient's very, very ill and they're admitted, if they're very severe, ID will use IV amphotericin. That is got a lot more risks associated with it. That's why we save it for patients who are having very significant reactions. All right, what do you think? 5 minutes? 10 minutes? We're at the 50-minute mark-ish.
5?
5. All right, stand up, stretch. Now we're going to do Coxy, near and dear to my heart, as not an Arizona native, but I lived there and trained there, so my family's all there now, so. Coxsackie is the red one, so southwestern US and Mexico. So this is the kind of image you want to think about. You know, Colonel's brother-in-law who was out building, excavating earth for highways down in southeast Arizona, digging up the dirt. That's where this stuff lives. If anyone's ever been to Arizona, but they're very dry. This is something that a lot of our dogs get. So I've treated my Rottweiler for this at one point, and he was a big digger. So he would dig up the spores. So any kind of earth disruption, you're going to push these spores up to finding out what people do for a living, what their activities are, where they're doing those activities. Again, all important. And it's not important until it isn't diagnosed. So again, it's called valley fever. Immunocompetent patients are usually asymptomatic, so they don't even know they have it, or they think it's like a minor flu-like illness. This is a highly opportunistic infection with HIV patients, unfortunately. So I saw this, I think the most common time that I saw this when I was doing all my inpatient was for HIV positive patients. So highly opportunistic. It's in the dust, it's in the air a lot. Usually, immunocompetent people can fight it off effectively. So HIV positive, a very unique population. Again, that's why in most cases, they are managed by infectious disease. So primary, then about 40% are asymptomatic. Arthralgias, this is something to look out for. So we talked about, I think last session we talked about pertussis, and one of the maybe tiny little hint early signs that maybe it's pertussis, and you don't have to wait till they start whoop, doing that whoop, is some conjunctival changes. So sometimes diseases give us tiny little clues early on, and if we're perceptive to it, we can put it together a little earlier than it would take us otherwise. So I know backache is like super common, but when it marries up with a cough and fever, when it marries up with joint swelling, not common, but can sometimes be seen on these skin lesions as well. So keep your eye out for that. You can put it all together earlier rather than later. You did great. So this can make patients feel pretty crappy, and sometimes they don't even really have it, but it can cause significant symptoms that we're thinking is just not feeling well.
Are those skin changes only on the disseminated?
No.
Primary?
Primary, yep. Yep. So again, not significantly common. You know, you're not going to, not every patient's going to come in with these, but they can be early signs that you can pick up on. The joint swelling, so I had one of my first interactions with a PA ever was a civilian PA. She was awesome. At one point in my first assignment, I asked her, is it weird that I come to you with all my clinical questions instead of vice versa? She was amazing, amazing clinician. And she ended up getting Coxsackie, and one of her biggest complaints was the joint pain. And that's really how it took them forever to diagnose it. Even though we were in southeast Arizona, she had gotten this, and she started to have these changes on her lower extremities. Didn't necessarily have all this, but it was the joint pain and the kind of constant cough. She would get a fever, then it would go away, and it took them about 3 to 4 weeks where somebody finally ordered the serologic blood test and diagnosed her. So again, you get the chest x-ray, right? So maybe not on the first visit because you don't hear anything, and somebody's like fever, cough, but their vitals are normal, they're afebrile in clinic, it's been only going on for a week. You go, it's probably viral. I didn't hear anything. There's nothing significant on your evaluation. You're otherwise healthy. So I'm not going to order the chest x-ray. But if they come back a week or two later It's not a bad idea to consider elevating their level of care at that point. Not necessarily referring them, but what else can I think of? What else can I do? What am I not thinking of? Sometimes it's just like, hey, you're taking a little longer to get over this than most people, but you always want to think a little bit more. Do I need to do something else at this point? Up to and including referral. But try to work your way up there using your clinical skills. Disseminated again, just like the histo, it's very, very rare. This is the patients that we would see as soon as we got them admitted, especially if they're HIV positive, they would get a full panel of labs, and this would be on it. And then as soon as we saw Coxie, where do we give them? Fluconazole, itraconazole, or depending on infectious disease, if they were severely ill and they had no other contraindications, sometimes we would have to give them that. I didn't see this given amphotericin very often because of the toxicity of it. Most of the times we just try to support the patient in the ICU and get them on an antifungal. Don't memorize that. Huh? Salvage. Huh? Yeah. I don't know why I put this in here. I'm so sorry. Yeah, this is like not very, yeah.
Swish, swish.
Yeah, keep this out. I should have crossed this out. Because this is not really where we're gonna live, right? Obviously it's life-threatening. I don't know what salvage means. I'm sorry I put this up here. But the point I think I was trying to make is, well, which one do I use, Carnicola? Do I use itraconazole or do I use fluconazole? And you can use either one of them. This is, just a little chart that, somebody came up with recommendations. So do you have to follow it perfectly? If you don't have itraconazole, use fluconazole. That's the moral of the story. If you don't have fluconazole, use itraconazole. That's the moral of the story. So it's not that you can't use one or the other. You can use both. The variations are, for Coxie, it doesn't matter. You just pick one. So I think that's why, I think somebody probably historically said, well, which one do we use? And I think that's why I put that up there. But I will change that for the rest of the people. So that I'm not completely, wow, that's it, huh? Alright. So, Blasto's our last one. That's the yellow. Blasto is, again, on your pants, so I'm going to cover it. This is not going to be a very high yield for you. Understanding that there is something called blastomycosis, right? So it exists as a diagnosis. It's blastomyces dermatitidis. It's in South Central and Midwestern USA and Canada. And this is another one where you inhale spores. Most of these are inhalation of spores. They're mycotic, they're fungal. That's how they spread themselves. Somebody walks by, inhales them. Clinical features, right? Primary, most common. It's asymptomatic, it's non-specific fever. Very, very similar to the rest. This one, a little bit higher yield on the chest x-ray. So if the patient is not getting better, they come back to you. You get a chest x-ray. More commonly, you will see capillary lesions or a mass. This is a picture of it right here, capillary lesion up here. Very difficult to diagnose. So if you have a patient you suspect it in, and you see this pathognomonic capillary lesion, and you certainly want to order the culture or contact infectious disease, contact public health. Hey, I think I might have this case, and get more guidance on A, whether or not you have to make the definitive diagnosis. Because again, if you go down to the bottom, you can very easily order itraconazole or fluconazole. Low side effect profile, if you suspect it, if you got the capillary lesions. This is one where in the assessment, I would put probably that as the diagnosis. I would put abnormal chest x-ray findings, or I would put cough, or I would put some symptom, and then because I haven't performed a definitive diagnosis, I would say, suspect this based off of XYZ, this is why I'm treating it. If you know, could you find blastomycosis in the ICD-10 codes and put it there? Sure, you wouldn't be doing anything wrong, but technically, I wait to put those in there until I have a definitive diagnosis. Otherwise, I just put something more vague, something that I can confirm. I can say this objectively. I can say a symptom objectively, but then you go down in your clinical reasoning and say, well, this is why I'm giving him itraconazole or fluconazole, because I suspect this based off of history of exposure, symptoms, and chest x-ray findings. And then they're still not getting better, you refer. Alright, aspergillosis. So this is another mycotic infection. So this doesn't really have a specific geographic location. It is fairly ubiquitous. It's throughout the environment, in the soil. Usually patients get it and they're asymptomatic. So this is one of those where patients that we will see where this diagnosis is clinically significant are typically in our immunocompromised population. Three forms, we've got the allergic bronchopulmonary aspergillosis, and then these two, which we won't go in much detail on. This is kind of like our disseminated, and this is a kind of unique, it exists in medicine, so I'll expose you to it, but it's probably not something that's going to be clinically relevant to you. So this is the allergic bronchopulmonary aspergillosis. So we'd already had our asthma lecture, we already talked about it, but this comes back up again. When I worked with Dr. Brown, who was an immunologist at Madigan, one of my, probably number 3 of my favorite rotations, every single patient that got referred to her for asthma, if they hadn't already had a chest x-ray, got a chest x-ray, and she'd usually repeat it, and she'd always get an IgE level and an eosinophil level, every single patient. Unless, again, somebody had ordered it prior to referring them. But this was part of her routine care for all asthma patients, because technically by the time they made it to her, it had been determined by a primary care person that they were having challenges treating them. Either they couldn't get them controlled on enough meds, or the meds they were using weren't really doing anything. So in addition to making sure they actually had asthma, she would always screen them for this. It was just part of the routine care that she gave. And when she would see this, right, she would consider treatment. So oral prednisone. Doesn't seem intuitive to use a steroid for a fungus, right? I know. Every time I look at the slide, I'm like, because it just feels so weird to say, oh, we're going to use some steroid to treat this. But using a steroid resolves this infection. It helps to decrease the inflammation, reduce the fungal growth, and even though it's counterintuitive, it works. Right, sometimes we add antifungals to this. That's a good question. Yeah. I don't think it makes it worse, I just think it doesn't get at it. Yeah. I think it's more, I just don't think the inhaled steroids are effective in, maybe they help a little bit, but they're not effective in resolving it. And maybe they do work in some patients that have it, enough that they don't continue to have symptoms. Yeah, but typically if they're still having exacerbation of symptoms, they're probably, hopefully already on an enough steroid, but they're still obviously having symptoms down there. But I bet you a certain proportion of these patients are probably controlled enough on that they never even have to get tested for it. But it should be. You need to consider that as maybe another reason. Maybe they're on aspirin. Remember the aspirin one? So this is another one. All right, this fleeting pulmonary infiltrates, it's kind of a weird one. Now they're there, now they're not. So it's kind of one of those things where maybe they've had 8 chest x-rays in the last, because they keep going to the emergency room, or they keep going and seeing someone that keeps ordering one. Well, we saw this 2 x-rays ago, and now it's gone, and then somebody gets another one and it's back again. So it causes these pulmonary infiltrates, but they'll kind of come and go. And this is, again, you're not, part of the management isn't to get serial chest x-rays. This is just one of those hints that we have figured out for this particular disease can be a clinical hint that maybe we need to start thinking about this. You hear it and you're like, wait a minute. So 3 chest x-rays ago, they saw it, and then the last chest x-ray wasn't there, and the one we did today, we see it again. Like, that should tickle something in your brain. You've heard about this before, and maybe you need to consider testing for it. So allergists, that's who we referred all of our difficult to treat asthma patients to. I thought they were the most appropriate and did the best job with it. All right, so invasive, I will not cover these in much detail, understanding that it exists, and very, very unique population, immunocompromised adults. If you have the opportunity to do infectious disease in phase 2 as an elective, I highly recommend it. And high mortality rate, 50 to 70% of people die from this because they simply cannot mount an immune response. And it just, anybody an X-Files fan? No, probably not. There's this one old one where the porta-john, where they open the porta-john and it's just coated with fungus, like it grew within 24 hours, so it's some alien thing. But that's what happens inside people's bodies is their immune system can't do anything, and so it's like mold on the bread with nothing stopping it. It just keeps growing and growing and growing and growing and taking over. And then this is a very unique, you may, I don't know why I made it red. I'm not gonna ask a question about it. But this is just a very unique clinical finding. It's associated with the diagnosis. I don't know if I told you guys this, but I used to have this really annoying pediatric resident who was when I was on rotation in peds in residency. And she was this real chippy, happy person every day. And anyway, so she would always point to the middle of her forehead. I don't know why she did this, but she would be like, what suture is this? And I'm like, there's no suture there. And she's like, it's the mitotic suture. And she would do this real goofy thing, mitotic. And I'm like, ah. I just couldn't. So how about this? Fast forward, I'm taking my boards. I swear to God, there's a picture of an infant's skull, and there's a suture, and there's an arrow, and it says, what is the suture? And I was like, that? So, test questions come from the weirdest places, right? Like I expect you to saying that. But I remember looking at that test question, and I was like, God's got a sense of humor, for sure. But I got it right. Did
you call her and thank her?
I did not.
I lost it.
I don't even remember her name, actually. I remember her face. I just don't remember her name. I should have, though. But I was like, man, hey, the fungus ball, right? Aspergillosis, right? Just in case you ever get a pants question and you see fungus ball, you're like, oh, how close is that to remember the test? But corn exposure, all this stuff. HIV pneumonia. Again, we call this HIV pneumonia because it's the closest correlation with HIV. It doesn't mean that HIV patients can't have, we just talked about several different pneumonias that are opportunistic infections for HIV. This one is just classically associated with it, such that now we use that term HIV pneumonia in clinical practice, and as a clinical community, we agree that we're talking about this PCP, not the drug. We're talking about the fungus-based nucleic acid. When I went through training, we still called it P. carinae, and we considered it a protozoa. Fast forward some years, now we call it, I think they were making the name change as I was a resident. Now we call it P. jerevecki, and have transitioned, now we call this a fungus-based nucleic acid, which is why we include it in the mycotic pneumonia section. So. P. Jerevecki, aka PCP, aka pneumocystis pneumonia, aka pneumocystitis. All mean the same thing. Sorry. Class-based associated with AIDS. Test questions will definitely start with HIV positive patient with a CD count of 100. So that'll be your buzzword, that'll be your clue. So what do I have to remember? I have to remember that it's P. Jerevecki. I have to remember it's also called pneumocystis or pneumocystitis. Another clue, maybe, that Colonel Cola said it had a chest x-ray that was diffuse interstitial pattern. All right, some diffuse, nothing focal, nothing loculated, nothing apical, nothing hilar. It's just all over. This isn't normal lung picture, right? It's a little bit more dense. There's something going on. There's something that's causing increased density because it's showing up more white. It's usually fluid. It's usually some sort of inflammatory process, but it's throughout everything. The diffuse bilateral interstitial pattern. You can diagnose it with sputum or bronchoscopy lavage. Just like pertussis, right? Remember we said azithromycin for pertussis, TMP SMX for PCP, or Jerevecki or pneumocystis. So this is one that has been used. I haven't seen any recent changes in it. It works. It's what we still use. Because it's a smaller population that we use this on, we haven't had a lot of significant resistance, so we haven't had to come up with any other regimen for this. So this is one I would put in the vault. But that's what you need to know about PCP, not PSP. And then you guys have a long lunch.